Thank you. We weren't live, but thank you so much for those of you who have clinked your glasses so that you'll pay attention up here. Good afternoon. I'm Corleen Kraft. I'm president-elect of the City Club, and we would like very much to welcome you to the City Club and the David Lawrence, MD lecture, co-sponsored by the Foundation for Medical Excellence. This afternoon's lecture will be presented by former Governor John Kitzhaber on reframing the national health care debate, challenging our basic assumptions. Perhaps introductions are in order since we're co-sponsoring this event. City Club members, I would like to introduce you to the Foundation for Medical Excellence, which is a foundation, public nonprofit foundation created in 1984 to promote quality health care and sound health policy through physician education and research. Educational topics are derived from contemporary medical issues facing practicing physicians and currently include programs on inappropriate prescribing, physician well-being, sexual misconduct, medical peer review, and physician-patient communication, which is always a good one. And guests, I would like to introduce you to the City Club. City Club is also a nonprofit organization, and it provides outstanding Friday Forum speakers, widely respected research reports, such as the recent in-depth report on community policing, and studies on a variety of topics, such as ballot measures on the current PUD effort. City Club's mission is to inform its members and the community of public matters. We're delighted to have collaborated with you on this project, and if you support City Club's efforts, we would like to extend a special invitation today to all of you to become members. There is membership information on all of the tables. And for those of you who are already members, or for anyone who wants to support City Club in its efforts, we would be delighted if you would make a contribution to the annual fund, and envelopes for that are on your tables as well. Before we begin our program, there are, as usual, a few items of City Club business to mention. Next Friday, October 24th, please join us for the program known as The Heart of Baseball, Why We Love the Game. That should at least generate some interesting questions, shouldn't it? The author and former Major League Baseball player Larry Colton will be the presenter. You can reserve a place for this program at www.pdxcityclub.org or by calling the club office. And in case you thought we were all work and no play, let me disadvise you. Not only do we concentrate on serious matters, we also know how to have fun. On Saturday, November 1st, City Club's New Leaders Council will join with the Blue Monk Restaurant and Jazz Club and the Original Cats Jazz Blues Band to celebrate the work of new leaders in City Club. It's a modest fundraising event since it's only a $10 admission fee, and it's also open to the public, but half of all the admission proceeds will go to the City Club's annual fund. So the doors open at 7:30. The Original Cats will perform from 8 p.m. until midnight. So please join us on November 1st to have some fun and support the club. And finally, due to scheduling conflicts, the celebration of the 30th anniversary of admission of women to City Club has been rescheduled. The new date is Monday, November 24th, and it will be held on the first floor of City Hall from 5:30 to 7 p.m., and that correction will be in the bulletin. Join Mayor Vera Katz, Gretchen Kafori, Pauline Anderson, the first woman president of the club, and others who blazed the trail as they recollect the beginnings of City Club women. Please RSVP at the City Club office to Cullen Brady. I would like to mention two names that are very important to City Club: Washington Mutual and Portland General Electric, who are underwriting the broadcast of our programs this quarter. We're very grateful for their support. And now for the pièce de résistance, we are enormously pleased to have Dr. David Lawrence on the dais today. This lecture series was named for him because of his contribution to medical excellence. While he won't be speaking, we wanted to honor him by seating him in front of you. Dr. Lawrence earned his BA from Amherst, his MD from University of Kentucky, his MPH from the University of Washington, and attended the Advanced Management program at Harvard. He was CEO of Kaiser Foundation Health Plan and Kaiser Foundation Hospitals until retiring as Chairman Emeritus in 2002. He has served on many boards of directors ranging from Agilent Technologies, Pacific Gas and Electric, Raffles Medical Group of Singapore, which must have led to some nice trips, and the RAND Health Advisory Board. And now to our speaker. It's such a cliche to say that this person needs no introduction, but in the unlikely event there are extraterrestrials in the room, let me just proceed to give a little background information on him. He's a former emergency physician, a legislator, and two-term governor of the state of Oregon. He's widely known as the father of the groundbreaking Oregon Health Plan, which he authored and implemented during his term as president of the Oregon Senate. This program has received national attention and is now in its 9th year. In 2003, Dr. Kitzhaber began serving as president of the Estes Park Institute, which conducts 6 annual education conferences for community hospitals. In addition, he holds an endowed chair on healthcare policy with this Foundation of Medical Excellence, our co-sponsors today. It's widely acknowledged that the healthcare system in this country is not working. The inability of so many to afford health care has been hugely exacerbated by this economic downturn. Proposed solutions for reform of the system have typically been tied to an expanded role by government and maintenance of the entitlement programs. But Dr. Kitzhaber believes it's time to challenge these long-standing assumptions and reframe the debate on national health care. You've been known in the past to think outside the box. We're sure you have some provocative ideas for us today, Dr. Kitzhaber.
Thank you. Well, thank you very much. It's a great honor to have the opportunity to deliver the David Lawrence Lectureship and to have the opportunity to visit with David again, who's been an individual I have admired greatly over the years. And it's very good to be back here at the City Club. I also would like to thank John Uelling and the Foundation for Medical Excellence for creating this particular lecture and also for providing me with the opportunity to keep my hand in health policy. As you know, I've been involved in the healthcare system now for almost 30 years, first as an emergency physician, then as a policymaker, and of course occasionally as a consumer. Today I'd like to share with you 2 conclusions at which I have arrived as a result of these experiences. And it's my hope that these conclusions and an examination of the thinking which underlies them will prove useful in the growing debate over the future of the U.S. healthcare system. But it's also my hope to motivate you to take action here at home instead of simply waiting for somebody else to solve this problem. My first conclusion is that we cannot solve the problem of our healthcare system without first establishing an explicit policy of universal coverage. And as a corollary, to that conclusion is that we cannot successfully use a competitive economic market model to deliver health care to the medically indigent. My second conclusion is that we cannot have a meaningful debate about health care reform in this country without a willingness to examine the underlying assumptions of our current federal system, and in particular, Medicare and Medicaid. Now let me take a moment and touch on each of those points. Perhaps the most fundamental shortcoming with our current healthcare system is the fact that we have failed to answer the single most important question in the healthcare debate, and that is who has the responsibility to pay for the care of people who cannot afford to pay for it themselves. And our failure to do so, our failure to adopt an explicit policy of universal coverage, has led to the cost shifting, the adverse selection, and the disproportionate sacrifice, which are tearing the system apart and creating deep and bitter divisions within the provider community. Adverse selection, of course, is the widespread practice of trying to avoid those individuals who are sick and who can't pay, and trying to gain those individuals who are healthy and have a way to pay for their care. Disproportionate sacrifice is a reflection of the fact that some providers see far more poor people than do other providers. And cost shifting is the primary tool by which we avoid confronting the fact that we have no explicit policy of universal coverage. Consider the fact that both public and private healthcare financing systems operate in the same undifferentiated economic competitive market. And for poor people to gain access in that market, they have to have a way to pay for their health care. But we know that a lot of people don't have the ability to pay for their health care, and often the reimbursement that's available to those who are eligible for public programs is considerably lower than that available through commercial insurance. So in such a system, with no clearly delineated responsibility concerning either who pays for the cost of those who can't afford it or who provides that care, we leave the market to make that determination. But economic markets are designed to turn a profit, not to foster social responsibility. So it should come as no surprise that nobody competes for those who can't pay. And in today's market terminology, people with a payment source are referred to as market share, and we go out and compete for those. And people who can't pay for their health care are called liabilities, and we seek to avoid them through adverse selection and cost shifting. Now, the ability to cost shift serves as the pressure valve in the system, and it also reduces accountability and thus the political pressure to enact meaningful reform. And here's how it works. Because of the growing cost of health care, almost everybody relies on some third party to help finance the cost of their care. And of course, the major third-party payers in our system are the government through Medicare and Medicaid, and the business community through employment-based coverage. People who don't have third-party coverage, either through a governmental program or through the workplace, often are unable to afford the cost of their care. They fall into this coverage gap that now contains over 44 million Americans. And when they get sick enough, they gravitate to the emergency room, and those costs that are incurred are shifted back to the system through incremental increases in your premiums or your bills. Now, these two major third-party payers also face fiscal constraints, and when costs rise above a certain point, they respond by trying to shift that cost somewhere else in the system. And the operative word here is shift, not control, but shift. Now, states which have the primary responsibility to care for the poor shift cost in two ways. First, they change or manipulate income eligibility standards to reduce the number of people who are eligible for the Medicaid program. That shifts cost to people who have no way to absorb it and amounts to a form of implicit rationing. States also cut reimbursement rates, which shift cost onto providers and shows up as uncompensated care. And at some point, providers stop seeing or try to avoid seeing these individuals, which amounts to another form of implicit rationing. So instead of giving everyone coverage for something, we give some people coverage for everything and other people coverage for nothing. Instead of explicitly making a list of benefits and drawing a line, we implicitly make a list of people and draw a line. Now, employers use essentially these same cost-shifting strategies, either dropping people from coverage altogether or increasing co-payments and deductibles, which shift out-of-pocket expenses to individuals who at some point can't afford the cost. And costs are shifted to providers through prepaid discounted managed care contracts. And of course, these actions simply serve to increase the number of people in the coverage gap who eventually gravitate to the emergency room, are seen and treated, and the costs are shifted back to the system, continuing this cycle. Now, this situation has two very, very serious consequences. First, as a society, it is costing us far more to leave a huge segment of the population without coverage than it would to establish an explicit policy of universal coverage in the first place. And why is that? It's because people who don't have the ability to pay for their care still get care, and ultimately we pay those costs. Let me give you a tragic case in point. Earlier this year, as you know, in order to save money in response to the state fiscal crisis, the legislature discontinued prescription drug coverage for people on the medically needy program and those people on the Oregon Health Plan standard benefit package. Now, that action was apparently based on the assumption, widespread in legislative circles, that if we just stop paying for the health care of these poor people, they somehow go away somewhere, and we can avoid picking up the cost. Now, as a consequence of this decision, a man in his mid-30s suffering from a seizure disorder was no longer able to afford his anti-seizure medication. So he was still eligible for Medicaid, but he wasn't eligible for the prescription drug benefit, which was no longer covered. He subsequently went into a sustained grand mal seizure and suffered severe brain damage and ended up on a ventilator in a Portland hospital. Now, the cost of his seizure medication was about $14 a day. The cost of his ICU stay was over $5,000 a day, which was billed right back to the state Medicaid program because hospital care was covered. So, did the legislature save any money by this decision? Absolutely not. On the contrary, it increased the fiscal liability, and in order to absorb it, it forced them to drop more people from coverage, perpetuating this kind of human tragedy and fiscal disaster. So my point is simply this. We are going to pay these costs one way or another. We're going to pay for them explicitly, or we're going to pay for them implicitly. And by failing to do so explicitly, the cost will ultimately be far higher, both in human terms and in economic terms as well. Now, the second consequence of our growing failure to establish this explicit policy of universal coverage is the growing disruption of the traditional relationships among healthcare providers. Cost shifting and this competitive economic environment in which it exists has created huge inequities in the amount of cost borne by different healthcare providers, which in turn has pitted physician against physician, physician against hospital, and even hospitals against one another. As more and more people lose insurance coverage and as more and more people are unable to get timely preventive and primary care in the community, they gravitate to our hospital emergency departments, putting them under enormous strain. And this financial burden is not evenly distributed, with inner-city hospitals suffering far more economic liability than those hospitals located in the more affluent suburbs. Now, the casualties of this competitive zero-sum environment are cooperation and collaboration, leaving a vacuum that gets filled with a politics of scarcity, with the kind of division and conflict which undermines any larger sense of community purpose. Economic self-interest and perceived economic survival have replaced the larger community mission of our healthcare organizations. And without a sense of common purpose, no one group has the capacity or the designated responsibility to fill in the gaps of the system. And what gets left out are things that providers don't get reimbursed for or for which they receive no competitive advantage. And the driving force of this new dynamic that exists in this community and communities around the country is selection and competition for healthy paying patients at the expense of those who are sick and uninsured. Now, with no explicit means for either hospitals or physicians to make decisions about who will finance and deliver the care for those without resources, this kind of selection has become the primary tool of economic survival, feeding a vicious cycle which ultimately puts the entire community at risk. Now, this is a situation that urgently needs our attention, and it is one that is not entirely beyond our control, a point I'll return to in a moment. Now, as much as we need to establish an explicit policy of universal coverage in this country, enacting one will be virtually impossible unless we're willing to challenge the underpinnings of the current federal system, in particular Medicaid and Medicare. These two federal programs have been accepted parts of the healthcare landscape now for going on 40 years. And almost all prior efforts to reform the system have taken place around these programs with no serious challenge of the basic premises on which they're built. And unless we are willing to do that, we cannot possibly achieve our objective. And let's take a moment and examine why. In 1965, poverty among the elderly was nearly twice that of the general population, and older Americans faced a very real financial barrier in terms of access to health care. Now, Medicare was enacted in part to address that problem. It is an entitlement program that begins at retirement regardless of the income of the retiree. It provides coverage for acute care, but not for prescription drugs or long-term care, and it's financed largely through a payroll tax imposed on all those who are working. Now, that made a lot of sense in 1965, but the world has changed dramatically in the intervening 4 decades. The structure of Medicare has not. And as a consequence, the policies which underlie this program are very difficult to justify given the realities of today. First, Medicare represents an enormous and growing intergenerational transfer from the young to the old, from people who are working to people who are retired. Whereas 40 years ago, the elderly represented one of the poorest segments of society, today they represent one of the richest segments. But because Medicare is not means-tested, retirees are entitled to publicly financed health care paid for in part by workers who can't afford health care for themselves and for their families. Second, as health care costs continue to rise and as people live longer and as the number of retirees increase relative to the number of people who are working, the financing mechanism for Medicare is going to become increasingly unsustainable. And finally, while Medicare covers acute care, much of which is spent, often futilely, in the last few months of life, it covers neither prescription drugs, which are the mainstay for managing chronic conditions, nor a system of long-term care, both of which are necessary for older citizens to remain mobile and active and independent members of the community. Now, Medicaid was also enacted in 1965 to improve the financial access for certain categories of poor citizens. These categories established by Congress include poor families with dependent children who are on welfare, the blind and the disabled, the frail elderly in need of long-term care, since Medicare doesn't cover it, and certain categories of pregnant women. Medicaid, like Medicare, was enacted nearly 40 years ago and also reflects a set of policies that are very difficult to justify today. First, while Medicare provides an entitlement program for people in the category over the age of 65, there is no such entitlement for the poor in America. Eligibility for Medicaid is based on category, not on financial need. So there are many poor people who are not eligible for the program, even though they're deeply impoverished. So in other words, we've created in statute a distinction between the deserving poor who fit into a category and the undeserving poor who don't fit into a category. Second, the inflexible federal regulations that surround eligibility and benefit design force states into one-size-fits-all benefit packages and all-or-nothing eligibility decisions. And when costs increase, as I just mentioned, states have only two management tools, to manipulate eligibility or to cut provider reimbursement rates. And as we have seen, these tools simply shift costs onto providers and individuals and increase the barriers to access. So in short, the current structure of Medicare and Medicaid pose a significant barrier to achieving universal coverage. And I submit to you that any debate over the future of the U.S. healthcare system which sidesteps this reality is not a serious debate at all, but is one that's being driven by polls and partisan politics rather than by substance and purpose. And sadly enough, that appears to be the case. So in the interest of stimulating some good, healthy discussion, let me suggest two steps that our president and his would-be challengers might consider embracing. And since it's being delivered here at the City Club, I think the chances of that are great. Now, I appreciate that these proposals are somewhat provocative and will cut against the grain of conventional political thinking, particularly in our nation's capital. But it seems to me that it is, in fact, conventional political thinking that has earned us the dubious distinction of not only being the richest nation on the face of the earth, but one of the few industrialized nations that does not have a policy of universal coverage. In any event, as the late Western writer Edward Abbey used to say, society is like a stew. If you don't keep it stirred up, you get a lot of scum on the top. Okay, first, I believe that we must explicitly segment the healthcare market to create at least three tiers. A civic tier for those who don't have the ability to pay for their own care, a community-rated managed care tier, and a more self-directed and individually underwritten tier. Now, even the mention of multiple tiers in our healthcare system elicits waves of dismay and criticism from many quarters, something that we painfully learned when we attempted to gain our first Medicaid waiver for the Oregon Health Plan. But if you think about it, while we readily accept this reality in everything from public education to public housing, pretending that we don't have a multi-tiered healthcare system is one of America's most cherished political illusions, just like the illusion that we don't ration healthcare in the United States. The fact is, however, that we have accepted, at least implicitly, multiple tiers of delivery in this country for at least 40 years. First, you have the tier for people who can't afford the cost of their care but don't qualify for a public program. Medicare and Medicaid are two more tiers. Then there's a tier for people who have good workplace-based coverage. And there's another tier for people who can afford just about anything they want. We've got a lot of tiers in this country. It's just politically more convenient to ignore them and pretend they don't exist. I'm simply saying, let's be honest about it. Let's establish those tiers explicitly, and let's base them on a policy that we are willing to stand up and defend. Now, the civic tier, in some respects, is probably the most important tier because cost shifting and adverse selection and disproportionate sacrifice are all about how to avoid taking care of people who can't pay for their own care. As a consequence, we cannot successfully use a competitive economic market model to deliver health care in this civic tier, or to deliver health care to those people whose reimbursement is less than that offered through the private commercial insurance industry. So this civic tier needs to be separate and distinct from the competitive economic market environment in which the other two tiers will continue to operate. And why is that? It's because this tier would not be a competitive model, but rather a community-based model in which healthcare is viewed not as an economic commodity, but as a tool to achieve a common social objective, the health of the members of a given community. Now, all providers, all hospitals in a given community would participate in the civic tier on an equal basis. That is, the cost and risk of providing care would be shared equitably to reduce this problem of disproportionate sacrifice. A solid evidence-based benefit would be offered. Choice of providers would necessarily be more limited than in the other two tiers, and the care would be vigorously managed. And the civic tier would also be explicitly financed, which is something I'll return to in just a moment. That's the first step. The second step is to redesign our system for the poor and the elderly, who, by the way, are not necessarily the same. I would start by eliminating categorical eligibility and making all citizens eligible for the civic tier, including those who are currently covered by Medicare. Furthermore, this tier would be explicitly financed with all members of society contributing. To accomplish that, I would take the resources that are currently generated through the payroll tax that finances Medicare and redirect them in two ways. I would first redirect some of those resources to support the civic tier, which would give it the broad and equitable base of support that it needs. Thus, not unlike our system of public education, all citizens would contribute to financing the civic tier, but those with more disposable income could choose to enroll in either the community-rated managed care tier or in the individually underwritten tier. Second, an evidence-based supplemental benefit would be created and financed with the remainder of the resources from the payroll tax and with beneficiary premiums on a sliding scale based on ability to pay. But unlike the current Medicare benefit, this benefit would be specifically designed to meet the real health care needs of an aging population, including prescription drug coverage, including coverage for long-term care. Now, I want to make it clear that both Medicare and Medicaid have been enormously important programs in this country and have benefited millions and millions of Americans. And it's not my purpose in making these proposals to precipitate a political conflict between the young and the old and people who are working and those who are retired, or between the rich and the poor. But I would submit to you that our current system has already created that conflict, and I'm simply suggesting that we end it, and that we have the courage and the honesty to view Medicare and Medicaid through the lens of the 21st century, not the mid-20th century, and to openly acknowledge that these programs reflect a set of circumstances that simply no longer exists. Now, certainly there are many poor elderly citizens who need publicly financed health care, but the fact is there are many poor children who deserve publicly financed health care and currently have access to none. 11 million of our 44 million folks without insurance are kids. No entitlement, no health care, the future of this country. I believe that by basing eligibility for a public subsidy on financial need rather than on a set of arbitrary, outmoded categories, that we can actually improve the care for the elderly and for the young, that we can maintain the health of our workforce and the health of our retired population. These are not mutually exclusive propositions, but our current system structured it as though they were. Now, if we were to aggressively call the question on just these 2 points, explicitly segmenting the market to create a civic tier and redesigning Medicare and Medicaid, we would, at the very least, force the national debate to focus on the real underlying problems of our healthcare system. Unfortunately, I don't see the leadership necessary to do this coming out of our national political establishment. And there are 2 reasons for that. The first reason is that few people in public office today are willing to lose an election or even risk losing an election over an idea or a principle. And as a consequence, we rarely debate big ideas and principles in this country anymore, grinding the public discourse down to the lowest common denominator. The political debate in this country has increasingly become about the acquisition and retention of power, not the exercise of that power for some larger public good. And nothing illustrates this point better than the current vacuous debate about adding a prescription drug benefit to Medicare. The relative policy question here is not, in fact, how to finance prescription drugs for seniors. But that's as far as the debate goes on both sides of the aisle. The real questions we should be debating are, first, why do these drugs cost so much in the first place? The second question is, what health benefit are we actually getting for this enormous and growing expenditure? And in fact, if we're going to spend more money on health care, perhaps the single most important policy question is, where should the next dollar go? Why should we take the only group of Americans with an absolute entitlement to health care and finance a $400 billion prescription drug benefit on addition to their current entitlement before we provide basic primary and preventive care to 44 million Americans who currently are completely left out of the system? Yet who in the national political arena is asking those questions? Not the president, not the would-be Democratic challengers, certainly not the United States Congress. And I'm sorry, responding as this administration did to the news of the increased number of uninsured Americans by saying, well, only 1 out of 7 people doesn't have health care, just isn't good enough. Now, the second reason for the seeming inability to solve this problem has to do with us. It has to do with you and me and the way in which we facilitate and enable the growing dysfunction of our legislative process. Sadly enough, we have conveniently come to believe that it is someone else's responsibility to solve the problem in our healthcare system. And this attitude, of course, gives us as stakeholders, whether providers or consumers or third-party payers, the license to pursue our own narrow special interest at the expense of systemic reform. Ron Heifetz, who is trained as a surgeon and is now a professor at the Kennedy School of Government at Harvard, has a very powerful medical analogy for the kinds of problems that we're facing today and for how we have been trying to solve them. He classifies medical problems in 3 groups. A type 1 problem might be someone with bacterial pneumonia who comes to see the physician, and that person's physician gives them a prescription for an antibiotic and they get well. So in a type 1 problem, the responsibility for taking action rests with the physician, not with the patient. A type 2 problem might be coronary artery disease, in which you can come to the physician who can give you medication to manage your cholesterol and lower your blood pressure, but if you don't stop smoking and change your diet and start exercising, you're not going to get better. So in a type 2 problem, the responsibility for taking action is shared between the physician and the patient. And a type 3 problem might be terminal cancer, where cancer is not so much the problem as it is the condition. And the solution is for the individual and their family and the physician to work together to figure out how to deal with the reality of a situation that none of them can change. Now, today I think our problem is that we tend to view the challenges in our healthcare system as type 1 problems that don't, in fact, require shared responsibility to solve. We just need the United States Congress to do something, or the Oregon legislature to do something, or the courts, somebody. In other words, it's someone else's responsibility to solve this problem. The fact, however, is that most of the challenges in our society today, including those in the healthcare system, are type 2 and type 3 problems that cannot be solved without shared responsibility and joint action, without the engagement and the assumption of responsibility by the stakeholders and citizens in the communities where these problems are actually manifesting themselves. And unless those of us outside the United States Congress are willing to assume that responsibility, the political establishment in our nation's capital and in our state houses is simply not going to take it on. And we will see a continuation of this hollow partisan debate that leads only to the next election cycle and not to a meaningful resolution of this very, very pressing problem that puts all of us at risk. Now, right here in this community, and in communities across Oregon and across the nation, the growing number of uninsured and underinsured citizens is a type 3 problem. It's a condition. I mean, I hate to tell you this, but a truck full of cash from the U.S. Treasury or the Oregon Department of Revenue is not going to back up here and dump millions of dollars into the Tri-County healthcare system. So we have to stop waiting for it. It's not coming. Rather, we need to ask ourselves what we can do to take action ourselves. And it seems to me that in particular, hospitals and physicians and health plans need to take the lead in acknowledging that there are only limited resources available to take care of the entire community. They need to appreciate the importance of the whole. They need to recognize that while portions of the community have sufficient resources to pay for their health care, others don't. But they are all members of the community. They are all members of our community, and they all deserve access to quality care. So while a practice strategy or a business strategy based on selectively capturing those who can pay will add to the financial stability of a subset of healthcare providers, it will destabilize others who are less successful at that competition game, and ultimately will put the entire community at risk. So that means that we have to take the initiative to counter this competitive selection process by establishing a means of making explicit decisions about how to equitably share the cost and risk of financing and delivering care for those in the community with few resources. To do so does not require an act of Congress. It does not require a law being passed by the Oregon legislature. But what it does require is leadership and trust and a commitment to serving the needs of the community in which all of us live and work. Now, I'm not saying that by taking that action alone we're going to solve all our problems. There's a host of other related issues: the prohibitive cost of malpractice insurance premiums, the relationship between the health care we buy and the health we get, individual responsibility, the list goes on and on. But by taking the bull by the horns and by consciously attempting to reduce the selection and cost shifting in our community, in this community right here, we could add an important element of stability to the system. And this, in turn, would allow us to identify and isolate those additional actions that need to be taken by the state legislature and or by the federal government to enable and facilitate our efforts to address this problem in our own community. And I think there's something politically powerful and very compelling in an argument that says, look, we have put our own house in order. If you can't solve the problem, get out of the way and give us the opportunity to do it ourselves. And the fact is, we are not going to solve this problem by clinging to a federal structure designed for the realities of the mid-20th century. How long would Microsoft last if Bill Gates hung on to an operating system that was 10 years old, 5 years old, 2 years old? Yet we are clinging to operating systems that are almost half a century old and wondering why we can't solve the challenges that are facing us in the 21st century. As Albert Einstein once observed, we cannot solve problems by using the same kind of thinking we used when we created them. If we choose to do nothing, that's the collective we of the folks who live right here in this community. If we choose to do nothing, then by default, we are allowing the health future of this state and this community to become a matter of chance rather than a matter of choice. And I think we are better than that. This is our community, this is our challenge, this is our responsibility. Thank you very much.
Thank you. Thank you, Dr. Kitzhaber. Well, all you extraterrestrials out there now know who he is. As you know, as City Club members know, City Club members and only City Club members are allowed to ask questions of our speakers, and that is one of the main benefits of belonging to City Club. Should you so desire to ask a question and you're not a member, I already told you where the membership cards are. Our board host today is Bill Kramer, and he will ask the first question. He's currently Vice President in Kaiser Permanente, and he's a City Club member since 1999. He serves on the Board of Governors as Treasurer, and he also chairs the Finance Committee and is on the Program Committee. He's currently spearheading the Keeping Oregon's Promise series. Please line up behind the mics. I see this is what we do here. We have 2 microphones, and they start lining up while the question is being asked. Thank you. Bill.
Dr. Kitzhaber, thank you very much for your compelling message and provocative proposals. 10 years ago, the nation faced a similar crisis in health care, rising costs and increasing numbers of uninsured. That led to a wave of political support for universal coverage and health care reform, which led to the Clinton health care proposal, which ultimately failed. What are the lessons from those events, both on the policy side and the political side?
Well, I think the environment is significantly different today than it was 10 years ago. Some of us were talking about that this morning. I think one of the main problems with the Clinton health care plan was really a process, was both a structural problem and a process problem. The process problem is it was written in a closed room with Ira Magaziner and a handful of other certified smart people, and there was no opportunity for the people who were affected to actually have a buy-in or some ownership in the plan. I think that was part of the political problem. Second, it was really a way to finance the current system, which is essentially what we have in the debate in the current presidential election, just taking at face value the current system and trying to finance it. The change in the climate, I think the political climate in 2002 is far more partisan and mean-spirited than it was a decade ago. And I think that as I mentioned, this whole issue of sort of institutional economic survival of individual healthcare plans, of hospitals, of physicians and physician groups has become the dominant driving factor in the debate, with much less focus on the larger mission of why we're doing this in the first place. Healthcare has become largely an economic commodity rather than a means to achieving some larger social objective. So the climate's significantly different. And I really do believe that changing that has to start right here. That has to start in the community with people who are directly affected by the consequences of this dysfunctional environment.
I'm Ted Falk. I'm co-chair of the Healthcare Issues Committee at the City Club, and I wanted to make a brief announcement. If you did not receive in the mail a copy of our report on gaps in healthcare, I think there are copies on the table as you leave, and we're having a follow-up report, a much bigger report that will be published in January on the healthcare safety net. I did want to ask Governor Kitzhaber a question about the three-tier system. Now, when you were governor, you taught us to think in terms of a two-tier system, the community system and the civic system, and I wanted to ask about this third tier. And I think we're very grateful to John Uvelling as executive director of the Foundation for Medical Excellence, for Steve Gregg and Ralph Crawshaw sort of putting this issue on the table. But what is the policy justification for this third tier, the individually underwritten tier?
Well, to me, it makes less difference how many tiers you have than that we openly acknowledge that we are going to have a tiered system. They have been I was down in Australia a month ago. They have a tiered system in Australia. They've had universal coverage forever. They've got a parallel private hospital system. You can buy private health insurance and you get your knee done tomorrow as opposed to 4 years. So, I mean, it happens. We just need to acknowledge that. That's just, so that the explicit nature of establishing the tiers is the most important concept. The second one is you've got to have some kind of a safety net where the dollars that's available to everybody. Now, whether you have 1, 2, or 4 tiers above that, I don't think is as relevant. I think the reality is that there are certain individuals who have significant disposable income. And if they're willing to assume more personal risk, more out-of-pocket expenses, they should have more choice. It's really an acknowledgement of the fact that in this society, choice is a function of disposable income. And I think that's true in healthcare as well.
Hi, I'm Susan Pierce, member. I'm also a recovering emergency department nurse and who's moved into home health, hospice, and home infusion for Kaiser. I thank you for everything you said, and you answered a lot of my questions as you went along, but you didn't say much about nurses, physical therapists, occupational therapists, social workers, that group of people who actually often are the ones who are teaching the patient the doctor's instructions. And so could we talk a little more about the partnership between physician and patient, but also that those third members of the partnership and their role?
Well, I think having been the individual who gained the hopefully short-term wrath of the Oregon Medical Association by sponsoring in 1979 the bill that gave prescription writing authority to nurse practitioners, I think there is a very, very appropriate and absolutely necessary role for physician assistants, for nurse practitioners, for nurse midwives, for a variety of allied health professionals. We have an enormous manpower, person power issue in this system, with very little thought to where the folks are going to come from to man the system in the future. And I think that's going to require a lot of these debates, there is a legitimate scope of practice issue, which I think we need to all be sensitive to, but there's also a large turf debate, which becomes more acute when you have the perception of scarcity and really a shrinking pie. But I think that those kinds of conversations and discussions between healthcare providers, regardless of their degree, is absolutely essential. That kind of partnership is how we're going to stretch the dollars further and how we're going to keep people out of the system as opposed to simply taking care of them once they get sick.
Hello, I'm Roberta Palmer, a member of City Club and a member of Physicians for a National Health Program. And Governor, I wonder if you would agree that employer-based health care, as we have in this country, is very harmful to our economy in that it raises labor costs so that we don't compete well with the rest of the world, not only third world countries, but Canada. In some sectors, Canadian labor costs are 25% lower than American labor costs. Besides that, it keeps wages stagnant so that we don't have the consumer spending or savings that we could have. A single payer plan would eliminate a huge burden from American business and employees, free them up to leave jobs, retire early, or start their own business if they wanted to.
Well, I guess I'm not a person who believes that just by adopting a single-payer system you solve all the problems that face us. I mean, if what we're talking about is a single-payer system is closing down the employment-based system and increasing taxes or whatever to compensate for that cost, and simply financing the existing Medicare and Medicaid structure, financing the growing cost of medical technology with no consideration for the health benefit we're getting, I don't think you've changed the deck chairs on the Titanic, but I don't think you've solved the basic problem. So I think a single-payer system is both held up as the silver bullet and also cursed as something terrible. I don't think it's either. It's a way to pay for care. The larger question is, what is it we're paying for and what we're getting for that expenditure? And that's the one we just don't want to talk about in this country. So I think there's a role for it. I'm suggesting a single-payer system, I guess, in the terms of the civic tier. But I also think there's some value to having a competitive element to the healthcare system, as long as it's not being subsidized by the public sector at the expense of people who can't get access to the system, which is really the paradigm we have today.
Chris Allman, City Club member. I'm a physician and a mom, a relatively young mom, and I have not found it capable to balance the needs of being a mom and a physician, so I've opted out of the latter. And within the past few years, I've looked into the options of volunteering. It was a real eye-opener for me because I found that there were very few clinics that offered free or reduced health care, and that the margin over which patients qualified was barely over that which patients qualify for Oregon Health Plan. There was a huge gap, obviously, and it made me realize the shortcomings of the Oregon Health Plan. So my question for you is, as you've looked back on Medicare and Medicaid and see the historical shortcomings of Medicare and Medicaid, what do you see with what we can do with the Oregon Health Plan, or do you see that the slate needs to be wiped clean?
Well, I think the value, I mean, the Oregon Health Plan is not the answer, but I think it did teach us some very important lessons. I think to me, the transportable part, I guess, of the Oregon Health Plan is the establishment of an explicit priority list, which I think you just got to do. I mean, if you're debating the cost of health care without a priority list, it's really like debating the cost of a banquet without a menu. I mean, you've got to, so that, I think that the priority list is setting priorities, which is what you have to do when you're faced with high demand and resources that are out of balance. The second is the explicit process of the Oregon Health Plan. I think the explicit nature of the process was one of the reasons that it survived this last legislative session in spite of the budget problems. I mean, it's very clear what happens when you disenfranchise certain groups of people. But having said that, I don't think the plan can survive long-term without fundamental changes in the structure, the federal structure within which it's trying to reform the system. You've got this archaic federal operating system, if you will, that's really 40 years old, reflects a snapshot in time in the mid-20th century, and it enormously constrains the ability to be creative. I mean, the only national policy on universal coverage we have today is it's easier to get waivers to finance care for poor people by taking benefits away from poor people. I mean, that is the only policy that we have today to address universal coverage. And you can't get at that unless you're willing to take on the 800-pound gorilla, which is Medicare and Medicaid, and we just need to do it. You ready? Shall we? Should we take it on?
Yes.
See all the people who are 65 out there glowering at me.
Jane C., City Club member. I have a question, but I just got to say, thank God you're running around loose on the nation. I really appreciate it. But my question is there already formed or existing or beginning to form any national broad-based organization to which we could attach ourselves if we want to do anything about this? I mean, it sort of makes you want to take over AARP and make them do the right thing. But is there something somewhere?
You know, there really isn't. I mean, there are, the American College of Physicians has done a lot of policy work. I think we just heard about the Physicians for Universal Health Care. There are groups, but there's not really a coalition. The closest thing to it is something called the Center for Practical Healthcare Reform that's run by a guy named Brian Klepper, who's trying to put together kind of a broad-based coalition with a very short agenda to drive into the United States Congress. But there really isn't. I mean, I think you need to develop an alignment of interest with. I mean, AARP needs to be part of this. And you know, I actually gave my full Monty Medicare speech to the National Board of Directors of AARP and got out alive. And it's really how you frame it, because if the question is, you're going to take something away from us, and that's the concept, then nothing happens. But you know, the difference between AARP as a lobbying organization and elderly people is the fact that elderly people have children and grandchildren. And if you basically say, well, what we may be taking away from you is something that's actually not giving you a health benefit, and with that we're going to actually provide basic care for your kids and grandkids, it changes the fundamental nature of the debate.
Hello, Heather Kmet, City Club member. I love the fact that you pointed the finger back on us and said we can't wait around for Congress or the White House, or for that matter, any Politico to really get together, agree on how we're going to fix this, and we need to initiate that ourselves. Recently, my husband's employer gave us, in the small way, that sort of an opportunity. An option of the employer-covered health plan is to opt for the employer to pay for 100% of the health care costs up to $1,000. Then we pay 100% of the health care costs for the next $1,000, and then it goes to a more traditional percentage plan. My question to you is this. Number one, do you think that sort of option out there could perhaps reduce health care costs at the level where people can afford to pay? My second is, do you think that there are tools available for us to figure out how we can reduce those care costs ourselves? I mean, we looked at each other, we didn't even know how much some of these medications were actually costing, because we had never paid the full amount for them. And then the third is, as a non-medical person, how do we, besides in this minute opportunity that we've been given by my husband's employer, how do we really take action and not wait around?
Oh, well, that shouldn't take long to answer.
I've
think,
never asked you easy questions.
Well, I think I think that kind of creativity is important, and I think it's something that needs to be encouraged. But I think the part that I didn't really get into today is that, you know, even workplace-based coverage is subsidized. I mean, the employer contribution to an employee health care benefit is not counted as taxable income, and that contribution isn't counted as taxable income for the employee either, which is a huge public subsidy for everybody with employment-based coverage, and it's paid for by everybody who doesn't have employment-based coverage and can't afford health care. So there's just some basic inequities, and the other one is you have to get rid of the cost shift from the people who can't afford their care at all. If you don't deal with those two, you really, I just don't think you can get at the larger issue. And those are very tough, entrenched issues politically, but I think the real downside is I don't think people appreciate the consequences of clinging to this unsustainable system. You know, you may involve giving up something now, but there's a lot more at risk. Take a community in which this adverse selection essentially, or a community where you got these cardiac cath labs and various things that suck money, paying patients out of the community hospital, leaving it to pay for the intensive care unit and the emergency department, which never pay for themselves. Pretty soon, your community hospital closes, and then the whole community really suffers. So I think it's very, very important for people at the local level to begin to actually appreciate the consequences and the risk involved with doing nothing, as opposed to the risk of taking some bold action. And I know I didn't answer all your questions, but she's saving me here.
I think we have time for just one more question.
Hi, Barbara Clark, City Club member. I'd like to talk about another aspect of the train wreck in healthcare, and that is that with the baby boomer retirements, a lot of our healthcare providers, especially the most experienced, are about to turn into healthcare consumers instead. And so I'm wondering if the existing nurses and orderlies and technicians might be a pool of talent that could be more constructively drawn on with more of a career path for everybody who works in healthcare?
Well, I think it's related to that earlier question. I think the short answer to that is yes, but I also think that there's really no serious discussion going on in this country right now about the implications of the retirement of the baby boomers. It's going to double the size of the Medicare program, literally double the size of the Medicare program, which again is based on, you know, a set of certain realities that are a century old. And if we're not willing to go back and basically restructure the program, I'm not at all saying that people who are elderly shouldn't have entitlement to health care. What I'm saying is that the basis for the entitlement, the basis for the financing, the basis for the subsidy ought to be on a financial need. And there ought to be a much more sophisticated discussion about the health benefit we're getting for the dollars we spend on health care. Now, the somewhat controversial bill we passed in 2001 that sought to essentially compare the relative clinical effectiveness of various prescription drugs is a good example of the kind of evidence that has to be developed so that we stop talking about a benefit in a vacuum and recognize that a benefit isn't really a benefit unless it is associated with some positive health outcome. So restructuring the delivery system and developing the evidence to base health purchasing decisions on, I think, are the two things that are the only two things that are going to save the system from really collapsing.
As it happens, we do have some more time. We're getting a signal back there. I'm without a time clock today, so I think I've just gotten the message. 6 more minutes?
You're way over. I think you're way over.
What is the message? Keep going, that's the message. Gus?
Sir.
I'm Gus Mattersdorf, a member of the City Club. Dr. Howard Dean of Vermont keeps mentioning, but not at any great extent as far as I know, that everybody in Vermont is covered with, has health coverage. I don't know what that means, and I specifically would love to know how Vermont was able to do this, or what it would take for Oregon to do it.
Well, I'm not. I'm not able to comment on the situation in Vermont. I know Howard; he's a very good man, and I can comment on what his proposal for national health coverage is. Now, that may be based on Vermont, but essentially, it's an expansion of the existing system. He's going to expand eligibility for adults and kids up to the age of 25 under essentially Medicaid and the CHIP program. And then he's going to allow people over 185% of the poverty level to buy in, and essentially he gets universal coverage that way. But my concern with Howard's proposal, as well as everybody else's, is essentially it's a way to finance the current system, and the current system is broken. Unless we're willing to fix the current system, it doesn't matter how you generate the dollars. He's got a great website, however, and I'm sure it'll give you the answer. It's one of the best.
You mentioned that Clinton's health plan, one of the reasons it failed was process. So my question to you is, you've got a good set of ideas. What kind of process is needed to make this wider known and involve people in a way that they buy into it?
Well, you know, I think that things are possible in the state of Oregon that aren't possible in other states around the country. I mean, in terms of we had a meeting this morning that was basically hosted by the foundation. But you could sit down and make a list of 25 people in this community, both community leaders, civic leaders, political leaders, and members of the provider community, who could sit down and have a very meaningful discussion about what it would take to figure out a better way to allocate the risk and cost and deal with the cost-shifting adverse selection. Now, whether they would do it or not is a different question, but you could get those people together and figure that out. Those are the kinds of conversations that we need to start having. Because, you know, there is not going to be a white knight that's going to ride in here from the United States Congress to Salem and fix this. It's just not going to happen. And I don't know what we're waiting for. So I think those are the kinds of conversations that we could be having right here in this community. And, you know, we had them a decade ago, and it was a different environment. People weren't as strapped financially, and there wasn't the, you know, there was a big downside to what went on in the mid 90s with the expansion of managed care. There were a lot of casualties and victims, particularly among physician groups. But I still think you can have that conversation, and I think we should. I think we should start right here. Maybe the City Club can sponsor it.
Well, as I said, provocative, and I see no reason why City Club wouldn't be an excellent organization to take a look at this. I'm not promising, but let's go for it. Thank you so much, and hope to see you soon. Bye-bye.